We spent a lot of time at this conference hearing about pensions and hearing about taxes. And one thing that is a very big issue for states that we didn't spend any time talking about at all was health. And we thought that one way, and frankly, we do it a call for papers, we get what we get. But when we did want to bring the subject up, and so we thought we would address it with a panel, and I'm very, very pleased to have a great panel with me today. So we have Aviva Aron-Dine from the Center of Budget and Policy Priorities, Kate McAvoy from the Connecticut Department of Social Services, and Eric Kim from Fitch Ratings, who follows Medicaid developments. So we're going to have a really interesting conversation, but because we don't do a lot of health at these conferences, can you find it for me? I thought I would quickly go through some background facts on states and health spending, just so that we all sort of start with some knowledge. Thank you very much. Great. Okay, so health spending at the state level, which is mostly Medicaid, is a really big deal. It's a large share of budgets. You often see it done as state spending as a share of total spending, and in that case, health looks almost as big as education. I don't actually like thinking about it that way because a lot of Medicaid spending is actually financed by the federal government, and so it's not really a pressure. The part that's financed by the federal government is not a pressure point for the states. So if you think about state and local spending only out of their own funds, then health is about 20% and education is about 40%. So education is still big, but health is health is not quite as big, but it's still pretty big, right? The other thing, just in terms of thinking about health coverage, so Medicaid is a really huge deal for insurance in this country. So about 22% of the population right now has their health insurance through Medicaid. So just from a social perspective, it's an important program. Then, of course, there's all this stuff going on about the ACA and the Medicaid expansions. So as of now, about 34 states have expanded Medicaid so that all poor people are covered. 3 are now considering expansions, and the other 14 states are not adopting at this time, and we'll talk about what's going on in that arena. For states who have expanded Medicaid, the effects have been pretty dramatic, perhaps not that surprising, but if you look at the expansion states and you compare 2013 before the ACA started, and now you see a drop in uninsurance from 18.4% to 9%. In the non-expansion states, you see some drop as well, possibly coming from the mandate, the one-time mandate, but not nearly as dramatic. Okay, so Medicaid spending growth. So we all know that health spending tends to grow faster than GDP. It's a source of pressure for private insurance. It's a source of employers. It's a source of pressure for the federal government. It's also a source of pressure for states. Now, Medicaid spending growth has been quite a bit lower than private growth and Medicare growth, and we're going to talk about why that might be. Some of that is, it's a little hard to compare Medicaid spending growth over time because the type of people who are covered changes, especially with the expansions, and that's going to affect growth patterns. But nonetheless, no matter how you cut it, I think, states have managed to keep Medicaid growth more constrained than national health spending overall. Finally, looking forward, there are some long-term pressures potentially from aging. We talk about aging for the federal budget all the time. We don't tend to talk about it that much for state and localities. Here I have Medicaid per enrollee on the left and Medicaid per capita on the right. And the difference is that the probability of being enrolled in Medicaid really depends on age. So 65, you have Medicare. So Medicaid really only comes in for people who are getting some supplements to Medicare or who are in long-term care and nursing homes. So if you look, you can see that people who are enrolled, once they're 85 plus, are very expensive. And that's because nursing home care is a lot more expensive than just Medicaid health insurance coverage. If you look per age group and you sort of combine the probability of being in Medicaid times the cost, you do see that there is a rise with age. 65 to 84 is a little bit more than 45 to 64-year-olds. And then again, 85 plus is really where it hits. So looking forward with the aging of society, when we think about people getting into these older ages, that is likely to put some pressure on states. So what are the types of things we want to talk about today? So what are the issues facing the states related to medical care, Medicaid? So one is, what is the status of the ACA and the Medicaid expansion? What kind of stress risk from Washington? What kind of opportunities from Washington? We know that the Trump administration is very willing to think about a lot of Medicaid waivers. How do states think about that? Similarly, now that the federal government is kind of becoming more lax on the regulation of insurance markets. We've given up the individual mandate. What is the state role there? Will they step in? And of course, the opioid epidemic is something that I think we should talk about, which is something that is certainly affecting the health of people and mortality quite strongly. And the longer term, again, it's kind of risk from Washington. We've talked a little bit about bailouts this morning, and the question is whether or not we're going to have the opposite, which is that is Washington going to take its stress from Medicaid and healthcare in its budget and shift it back to the states by doing things like block grants of some kind. And then just generally looking forward, as I said, health spending tends to increase faster than GDP, and there's some pressure from aging. These two combine, how big are those stresses on states and localities, and how do the rating agencies think about that? We hear so much about pensions, we hear less about that, so I'm kind of curious about all that. So I'm going to just sit and have a conversation, and then we'll have time for Q&As. So thank you very much. All right, great. So again, to press this little mouth if you want to speak, I'm just going to ask questions and let you all just give your what you think, and you can just discuss amongst yourself as well. So one of the questions I have is, and maybe start with you, Kate. When we think about, I look at national health spending, and that kind of grows over time, and there's all the kind of discussion of why it grows. When states look at their spending projections or the spending on Medicaid, do they think it's something that they have control over, or is it something that's basically sort of handed to them from like just national trends, and then they have to kind of figure out what to do within that context?
So that's a great question. I'd say it's the viewpoint has shifted considerably in the ACA area. I think historically the view was that there was a fairly unbounded year-over-year increases in Medicaid spend, and that the program was looked at predominantly as a payer, not really having the tools and levers to exert influence to care delivery and value-based payment reforms. What occurred with the ACA, there's obviously an incredible range of foundational elements of the ACA for Medicaid, but one of those pieces really was to give states the tools and strategies. Expansion is just one of those to capitalize the work in a way that enables projections around savings, around pulling back the cost trend, tools around expanding the array of preventive services, tools around care coordination, particularly integrating behavioral health services, value-based payment approaches, and the flexible authority, and then the upfront funding to engender those efforts with providers and provider systems. So I think that has enabled a more sort of purposeful approach. It is also much more the case that states feel that they must self-actualize in this area, that they can't leave this to the vagaries of the policy decisions of the federal government.
I think I would add, from what we have seen looking at state budgets and talking to states, that trend really bears out, that there has been a slowdown in the growth trend in Medicaid. We just put out a report on enacted budgets for the current fiscal year that just started for most states on July 1, and the growth levels are much lower. They're more in the 2 to 4% range than what we've seen in prior years, and that has been trending down. Part of that is simply enrollment growth has slowed. We're in the 10th year of an economic recovery, so you'd expect that to be the case. But there have been substantial changes on the part of states in terms of managing costs. So the per member, per month cost, if you will, the per enrollee cost for Medicaid, those numbers are actually, the growth numbers are slowing there as well. So definitely that is showing up in the data. And that slide earlier is showing where Medicaid trends are in terms of year over year relative to other payers is pretty compelling.
Thank you. With respect to changes in, how worried are states about what's happening to the support for the Medicaid expansion, for other supports from the ACA, and how much do states like the potential for waivers? So.
I think there's sort of two categories of risks for states, both of which you just alluded to. There's the larger, what I would call existential risks, which would come from legislation like was discussed last year in 2017, coming back on the table. Hard to predict how that might play out. ACA repeal bills were obviously defeated last year, but remain under discussion. We just saw the new plan out from some conservative think tanks. The administration just reiterated its support for a plan along the lines of the so-called Cassidy-Graham bill. That would have two very large effects on states. First, a plan along those lines would completely wipe out federal support for coverage for the non-elderly populations covered by the ACA, the Medicaid expansion, and the premium tax credits through the marketplaces, and replace them with a block grant to states that wouldn't adjust to need and would probably grow more slowly than healthcare costs. And then the other piece would be a so-called per capita cap on the base pre-ACA Medicaid program, which is really another form of a block grant that limits costs per enrollee rather than in aggregate, but has that same effect of really shifting risk. So you sort of alluded to, is healthcare costs something that comes at states out of their control versus something they control? This would put much more of the risk of overall systemic trends, whether in demography or in healthcare costs, onto states. I think the second category of even more immediate risks is what's coming through some of these waiver policies. And, Kate, you talked about the ways that states are really using Medicaid expansion and other opportunities provided by the ACA to change their delivery systems. A lot of that has to do with coordinating care and continuity of care. And all of the sort of unprecedented eligibility restrictions that CMS is now allowing in Medicaid or even encouraging in Medicaid, whether that's taking away coverage from people not working a set number of hours per month, or premiums at lower income levels, or various forms of what are called coverage lockouts, where if someone doesn't renew on time, they can be locked out of coverage for a period. All of those will have the effect of increasing churn in periods without coverage, which I think, Kate, you can probably speak to this in a more granular way, but my perception from having worked on some of this at the federal level is would really threaten a lot of those initiatives, whether bundled payments or other forms of value-based purchasing or care integration.
I think that's wonderfully said, and I think those risks are very top of mind for Medicaid directors, particularly in expansion states. Expansion has meant, as Louise said, that we had a vastly greater investment by the federal government in the match for the services. Initially, 100% of the costs of the expansion population were borne by the federal government. That's graduated down, and presently 94% of the costs are borne. That would be catastrophic for states that are reliant on that vehicle to support the expansion population. Connecticut has expanded coverage to 240,000 individuals. That's a constituent part of about 800,000 total individuals served, and we would not have the wherewithal from the standpoint of our budget status to make good on that loss of expansion match. I agree also the structural change, shifting the program from an entitlement program where each and every eligible individual who demonstrates that he or she meets the required criteria for participation may do so, and there's essentially a contract between the states and the federal government that the federal government will subsidize those costs. Shifting to a per capita model is radically different in its orientation and also would necessitate careful examination of the adequacy of the trend rate going forward. States that have been efficient, and we are one of them, we've pulled down our PMPM. Eric talked about the overall reduction in per member per month costs, but looking ahead, you've got a lot of aspects, particularly the population of individuals who receive long-term services and supports that have the potential for significant growth in spend, and it would be very hard to calibrate that going forward.
That existential risk question is really important for us as well. We spent a lot of time last year as the bills were being discussed and debated in Congress talking about it and writing about this issue. And it's not just for states directly. What we have seen historically is that problems roll downhill in public finance. So when states face budget challenges, they just download those issues, right? So school districts in particular, higher education institutions, and healthcare providers when it comes to Medicaid, they suffer the consequences of states having to manage those issues. So if there were changes in terms of how the federal government pays for Medicaid and contributes to that program, certainly there would be stresses at the state level, but we think the stresses might be even more severe lower down. On the waiver question, I think there's actually been sort of mixed messages from what we get from what the administration has been sending out. So on certain things that they are in favor of, the things that Aviva talked about and Kate talked about, work requirements, things like that, clearly they're very supportive of that, and they've approved waivers and appear on track to approve others. The recent court case in Kentucky may throw a little bit of a wrench into that. But on other things, they've not been so supportive. Massachusetts had a waiver that was just denied a few weeks ago that would have made some pretty significant changes to how they do prescription drugs, and would have been the first time, I think, in the country that a state would have been allowed to do a closed formulary on prescription drugs and tiered copays, things like that, which everyone who has private insurance is familiar with those things, but it's not something that really exists in the Medicaid world, and would have been a really interesting way to see if Massachusetts could get some real savings out of that. But that was denied, and they also interestingly denied Massachusetts' proposal in that same waiver application to shift their ACA expansion population to what sounded like what Arkansas had, the subsidized private market insurance model. And there wasn't really an explanation for why the federal government denied that. They just said no, which is a little confusing because Arkansas has had that model since 2013. So from our perspective, there's been a little bit of mixed messages from what the administration has said about waivers and flexibility.
Yeah, on Massachusetts. Oh, I think it's on. On the sort of quote-unquote partial expansion question specifically, I do think what Massachusetts was proposing and what Arkansas is now proposing is a little different from what Arkansas has in place. What Arkansas has in place is Medicaid expansion coverage provided through commercial plans, but with the financing matching the financing of expansion, whereas what Massachusetts and Arkansas were requesting was effectively for the federal government to take on full financial responsibility for this group, which is something that neither this administration nor the last administration was willing to. Okay, but I think your broader point about different forms of flexibility and different reactions still very much holds. I think another example is when Virginia was having its discussions of expanding Medicaid, the OMB director, McMulvaney, actually weighed in to say, no, they shouldn't, because this administration will be trying to make legislative changes that would undermine expansion. So that was not only sort of in tension with the rhetoric of state flexibility, but really an unusual interference in a state's legislative process. Another aspect of the expansion issues that both of you were alluding to that might be of interest to this group, which I think we've paid less attention to probably because we haven't seen a recession since the ACA was enacted, but the expansion really strengthens the already significant role of Medicaid as an automatic stabilizer for states, both because of that enhanced match and just because it made the program bigger, but also because it pulls in a population that is particularly susceptible to, losing their jobs, seeing their incomes fluctuate during a recession. And so people who have simulated this looking backwards find that Medicaid would actually be much more responsive to changes in otherwise uninsured populations going forward, assuming that states take up the expansion and that federal support continues at its current level.
Now, if we had per capita caps, would that continue because it would still at least be with the people, or is it, or would that sort of diminish it a lot?
I think that is the big difference between a block grant and a per capita cap, is that a per capita cap does at least change with growth and enrollment. So if you think about the set of risk factors that a state faces in operating a healthcare program, one is how many people sign up. So a per capita cap provides at least some risk sharing for that aspect, but then there's how much do they cost? Is there a new drug like Sovaldi on the market? Is there an opioid crisis? Is demography changing so that you're pulling in more expensive people? And all of those risks are shifted to states under both approaches.
Yeah, I think that's, exactly right. And that's where, the flexibilities, when we talk flexibilities, they're really different in their characteristics. As Aviva said, the flexibilities that have essentially freighted the eligibility process, work requirements and the like, which we don't regard as contributing, we in Connecticut and other expansion states do not regard as furthering reform goals of access and coordination and improving outcomes. By contrast, the waiver authority that's been sought by Massachusetts is really designed to kind of use those levers, purchasing levers. We are required otherwise under the Medicaid, the federal Medicaid law, to cover all FDA drugs. That really can have very irrational results when there's actually a broad range of aspects of efficacy and utility to members. That's definitely it. There's a lot of tensions around pharmacy coverage. By contrast, Oklahoma was just approved for a waiver that will enable enable them to do some value-based purchasing. But those types of waiver authorities, I think, are essential to supporting continuity and integration and coordination of care for people as we look at supporting people often over a range of years, by stark contrast to private health insurance payers where they would see people only for a sort of limited snapshot of their health experience.
Yeah, I'd never heard about that. So interesting, this idea that if you start to interrupt their care, then all of these new models really just don't work anymore. Now, how big of a deal for you is the opioid epidemic? Is that something that is a huge issue for you, as through Medicaid, or just in general as for health? Or
I think it's well acknowledged that we're all, confounded by an incredible crisis around opioids. I will say that the caveat to that is that there are parts of the country, the Northwest, that are still more grappling with alcohol addiction. So this is not a unidimensional view across the country, but certainly in the Northeast, this has been a public health issue that has definitely defied easy resolution. We have put in place many strategies around restricting the supply, around educating providers, around doing consumer literacy, around the potential for dependence. To speak forthrightly, although there are many of those interventions, the death rate continues to rise dramatically, and that is a very difficult scenario, and I think it's commended Medicaid programs working in a new way with their departments of public health, and that's traditionally been a failure point of that nexus between Medicaid and public health, and the ACA also did a lot to try to engender more of a marrying up of those resources. But taking that population health approach with the tools and strategies of Medicaid, which cover in many cases, particularly in expansion states, and a broad array of behavioral health services and substance use disorder interventions, that's another risk of loss of funding for the expansion populations, is the very people who are most predominantly incident in opioid dependence and addiction fall within our expansion cohort. So loss of those behavioral health services and those supports are regarded as another key risk around the expansion.
So a lot of times you hear things said in public finance that once you give benefits, you can never take them away. And, that's hopefully will continue to be true for the ACA repeal bills, but we never know. But one of the questions I have is for some of these states, you sort of mentioned that you couldn't manage it, but you were also talking about how repeal of the Medicaid expansion might actually hurt education spending and all that. So I guess one of the questions is, have states kind of some of the states that have had expanded Medicaid, are they sort of committed to providing health insurance in a way that they weren't before, and so they would have to kind of rejigger all their spending if Medicaid repeal happened, or would things go back in terms of the rates of uninsurance?
Well, so the costs for Medicaid expansion for states were not really, they weren't there at all for a few years, and they're starting to now take effect. Calendar year 2017, I think, was the first year where you went from 0 to 5% of a state match, and it's ticking up each year. So you are starting to see states now having to bear that burden, and that is actually accounting for, in some cases, rises in state spending. A lot of states, though, when they did expansion, also accompanied that with revenue measures that were specifically targeted towards generating the money needed to pay for that match. Indiana is one example. Virginia has something in place with the expansion that they just enacted as well. Numerous other states have done similar things. So they have kind of a match there to help pay for those items.
But what do you think would happen if the ACA were repealed so that the federal spending for that expansion population was no longer there?
Well, some states also included triggers, essentially, in their law that get rid of expansion if federal funding goes away. Virginia, I know, for example, has one of those. So specifically because of that concern that, potentially it's not a sustainable program, and certainly when there were repeal bills talked about last year. So if the funding goes away, then sometimes, in some cases, those states simply wouldn't have those programs anymore at all, which the implications, I think, for the markets and health insurance in those states are pretty significant.
I think there's just a difference between the very real stickiness of expansion that you allude to. I thought I was on. I think expansion is sticky in the way you alluded to, in the sense that we've seen a number of people, for example, start running for governor saying they would pull down expansion in their states and change their minds. Most recently, Mike DeWine already, after the end of his primary. But I think that's different from the question of what would happen if states had to pay 3 to 5 times more per person to continue to their expansions. I imagine that some states would try to maintain coverage for some part of that population, just like some states tried to cover some part of that population before the ACA, but it's hard to imagine that most states would be able to maintain coverage for a significant portion.
Yeah, and I think there's a big gap between the ideological commitment, which is, very typical of the Northeast states, and the financial wherewithal. So that would be a major issue, as I said, for Connecticut, just in terms of our having had a very slow recovery from the recession. We are committed. We have as a public value reducing the uninsured rate as low as possible. We came below 5%, and it would be incredibly reluctantly that there would be any move towards reduction in coverage, but the financial wherewithal really has to be there to accompany it.
Let's shift gears a little bit and talk about the long-term outlook for state spending on health. And, one of the things I find so interesting is that people, the muni market seems to focus so much on pensions and not on sort of long-run Medicaid Medicaid spending. And even when states are pretty good at sort of trying to control it, I think most forecasts, CBO forecasts for, excess cost growth in Medicaid still assumes that health spending is going to rise faster than GDP. And so you're going to get pressures from at least that, and also potentially some demographic pressures. So how do rating agencies think about that, and how do states think about that? Let's start with Eric.
So one thing that we like to say at Fitch is that there are some states that have significant pension problems, and we certainly don't want to ever understate those, but every state has a Medicaid challenge and needs to deal with that. I mean, it's about roughly 25% of most states' budgets, some much higher, some somewhat lower, but it's something that every state has to deal with. It's a huge piece of their budgets, and despite some of the cost management efforts, it continues to grow, and it's likely that it will continue to grow even further. I mean, you were talking about the demographics, and you had that slide in terms of the aging population, and I just want to hit on that a little bit. One thing that wasn't clear to me when I started working on Medicaid is that Medicare is often considered the program that covers the elderly, but Medicaid is actually what covers long-term care, which is arguably the most expensive piece of healthcare for the elderly. So that is a real risk, I think, for states and the federal government, because it's a shared program in terms of the long-term trajectory for costs. And what we've seen states start to do over the past few years, and Kate, you can talk much more to this, I'm sure, is shift towards different models for how to deliver those long-term care services, whether it's some kind of managed care model or something along those lines, and trying to get more predictability on those costs. I think it's to be determined whether that model works the same way as it does for kind of straight healthcare services. Long-term care services are much more complicated, but for states, I think that's one of the risks is going forward, the aging demographic and how to manage that.
Just to add one really obvious point, which is that budgets have two sides to them, right? Expenditures and revenues. And so while it's true that health tends to grow faster than GDP, that challenge for states is exacerbated to the extent that they're relying on revenue sources that grow slower than GDP, or are cutting taxes such that revenues grow slower than GDP. So, if you were listing off the sort of most significant healthcare decisions that states may be making over the next year or two, I would include in that list what states do in response to the recent federal tax bill, because choices like that will determine the envelope for dealing with any of these other challenges.
Good point. Let me just, before we open to the audience, I just want to ask one kind of question really of you, Eric.
I think it turned itself off.
It does turn itself off, so you have to remember that. So I should know that by now. So one question I have is, when a rating agency thinks about state health policy, I'm being just much larger. I think about some things about kind of money that is spent, on, expanding better health to poor kids or young adults, or, is it always just about the dollars and cents, or do, the same way you might say, like, spending more on infrastructure is going to be good for the economy, do we ever think about, well, this is something that's an investment as well?
We do very much try to be forward-looking in the analysis, and it is certainly driven by the dollars and cents and what the fiscal effects are now that we can see immediately. But we do try to think more forward-looking about what are the implications. You talked about infrastructure, right? So we obviously look at what's your debt burden now, what's your pension liability burden now, but we also try to assess, to the extent we can, what are your challenges going forward? What's your deferred maintenance? What are the major capital needs that you have not addressed that are likely to come down the pike? The difficulty there is a lack of reliable, consistent data to be able to do that across states, which is what I mainly work with. And for local government, that's a whole other set of challenges in terms of that, trying to get at that. But we definitely try to be forward-looking. It's a challenge of trying to get that data and being able to look at that on a consistent basis, because otherwise you're almost penalizing those entities that have the information and can share that in a real way, and saying, well, here are your needs, and we're going to assess that, but we're not able to do that for other places. So how do you do that in a way that makes sense consistently? Just on the health spending, before we get off it, we've spent a lot of time talking about Medicaid. The other piece for states, you touched a little bit on, is public health spending, obviously, but also spending for employee and retiree health care. OPEB benefits, other post-employment benefits are going to get even more attention, I think. The fiscal statements, the fiscal year-end statements that are starting to come out over the next few months will have some changes in accounting that are similar to what happened on the pension side. And there'll be some pretty big numbers the governments are reporting. And that, while the liabilities themselves aren't necessarily changing, they're just being reported publicly in a different place in the financial statements, literally going from the notes to the balance sheets. That may spark some more discussions and behavioral changes on that front. And then the employee cost for healthcare as well is a pretty significant piece.
We were talking about that before, and I was asking whether or not sort of the state spending for their employees and their retirees is part of the purview of like a health department. You said some places yes, some places no, or
Yeah, traditionally it has not. They've really been quite distinct. But for instance, in the state of Washington, they've developed a purchasing authority that has really brought together the planning and procuring on basis of the retirees and also the Medicaid program. And I think there are untapped opportunities there when you talk about optimizing, using the lever of a state's purchasing power that procurement rules and other constraints of the Medicaid program have really made that a difficult thing, but I think we could do more around that. I'd also argue, as a Medicaid director, there's opportunity costs, obvious opportunity costs in not investing in a robust Medicaid program. We serve probably 30% of a given state's children. So investing in an early stage with preventative services, ensuring appropriate developmental milestones, school readiness, and then later work readiness. These are really demonstrable pieces. If you don't do that, you have a certain result. And there's emerging literature that shows that if we appropriately invest at the younger ages, we are obviating, in many cases, the probability that an individual will become reliant on public benefits in their adulthood. It is a catalyst to someone being economically self-sufficient. So I think those pieces are important. And then also looking at how states can marry up spending across human services. This has been a deficit historically. We had a very narrow lens in Medicaid. For instance, as an example, building in the resources of housing subsidies in direct partnership with Medicaid benefits, as we have done for individuals who are transitioning from nursing facilities to the community, is an example of what you can do to stabilize someone and to look across the kind of silos of spending in the state budget, which states are traditionally very parochial about doing, I will say.
Yeah, just one really simple example of that opportunity cost idea and how we think about it. So Kentucky, we talked about work requirements. They have a work requirements waiver that was approved. There's a court case ongoing now where they recently, federal judge said that I can't go forward at this time. So as we think about that particular waiver, one of the things we considered is certainly Kentucky estimated that there would be pretty significant savings on the budgetary side for them and for the federal government, $300 to $400 million for them over 5 years, $2 billion for the federal government over 5 years because of enrollment declines. They projected about 95,000 fewer enrollees in Medicaid with the work requirements implemented over the next 5 years. And for us, certainly we look at the savings piece, but we also look at what are costs that might be associated with that. And there are a few that we think about. One, directly for the state governments and local governments, they're often either directly or indirectly providing aid to help support uninsured patients, so to healthcare providers. So if those people who fall off Medicaid don't have other options and aren't able to get other insurance, they become uninsured, then you risk having those people having to be paid for directly, potentially by the state or local governments. And then also the healthcare providers, which we also rate, not-for-profit and for-profit healthcare entities. they've benefited significantly, we have seen in expansion states. Kentucky is a place where, looking at that chart that you had for uninsured rates, declined significantly, had one of the sharpest declines in the uninsured rate post-expansion, and rolling some of that back would create some risk, we think, for the healthcare providers in the state.
All right, let's open it up to questions in the audience. Anybody?
Thank you so much. Good afternoon. And I forgot to compile the question, in a short and concise manner. But this is a very, very general issue that is, if we are going to be living as we believe as of 2018, but as I learned a little bit about the bio boom, the biotechnology boom, and how they are transforming the villages, cities, urban development, certification, even they're making new countries. So how, now I will try to kind of address this in a very, very basic, fundamental as ABC level, and try to help us out, please, how we should be navigating. Like, for example, I could be very somebody, but I don't want to be that somebody, and I want to be the same ordinary person, how I spent and invested myself through discipline, trials, tribulations to where I am today. And I'm more than about 50 years old now. And thank God,
Okay, let's thank you so much.
So what I mean is the healthcare is so important. And
let me think about...
Yeah, be very technical. I think there's no time to be wasting wishy-washy and trying to be very song and dance, like poetry and stuff.
So I'm going to, excuse me, thanks very much. So let me just try to translate your question into something that we can talk about, which is when we think about sort of changes in technology as we go forward and how those might affect the demand for health, and maybe changes in life expectancy and how big of a risk it's terrible that, we love increasing life expectancy, but is that a big risk on the Medicaid program too, that we're going to have longer life expectancy?
I think life expectancy, potentially, yes. The longer you live, the longer you have to pay for care.
Yeah.
Technology is a particularly interesting concern. So Kate talked about how under the current regime, Medicaid essentially has to pay for all FDA-approved medications. And we are now seeing development and implementation of medications that are beyond even the hepatitis C treatments that we saw recently in the past few years that we thought were incredibly expensive. We're seeing treatments that are several $100,000 per dose, genetic-based medicines for cancer, things like that. What happens when those potentially become eligible for Medicaid? That can be a real budget challenge, I think.
And I think there can be two sides to that, right? One is a challenge that we confront healthcare system-wide of distinguishing new expensive treatments that are really valuable from new expensive treatments that are not adding much incremental value. The second is the challenge of a drug like Sovaldi for hepatitis C that was, in fact, adding tremendous value in terms of quality of life. And it's interesting to think about the Sovaldi example where states found that very burdensome. The federal government paid most of the cost, and we didn't even notice it from a budgetary perspective. It was a blip. Because the federal government is well equipped to deal with year-to-year fluctuations in costs, and state budgets are not. And so examples like that might even argue for, I think, more risk-sharing in certain cases than we have in the current Medicaid program. And yet there's this whole policy discussion that we sort of started with of less risk-sharing in the Medicaid program, which would likely lead to, even more significant access restrictions for the new therapies, new technologies that have proven their value.
So I really appreciate that Aviva and Eric brought up the hepatitis C drugs. A lot of states in the first blush immediately put on a lot of restrictions to the drugs, so utilization restrictions that were related to condition and substance use disorder, et cetera. We took a very different approach in Connecticut. We negotiated a package of rebates for all of the hep C drugs as they emerged, and we opened up access. We said that we were not going to freight it with those types of constraints because we wanted to take the long view. We see people across a long span of their lifetime. We could anticipate savings based on the acute and other costs of liver disease, and on that basis, we're able to project for our finance people that we were actually making a very smart investment. That's hard in a 2-year or 1-year budget cycle, and I think that's the challenge for Medicaid directors is kind of overcoming that and taking a long view. And that's difficult for policymakers and for budget people.
So much.
David Wessel from the Hutchins Center. It's often said that rising healthcare spending is crowding out spending on all other things at the state level. Is that true?
I defer to my peers to talk more generally, but that has not been the case in Connecticut. Back to that message Louise told you at the top of the discussion, state spending for Medicaid in Connecticut has remained exceptionally stable over the period of the ACA implementation. And in fact, the reduction in PMPM that we've been able to achieve and the slight reduction in overall spend has meant that there can be new attention to investments in other parts of human services. I think as we look to, like I said, marry up the other human services supports, you can also transcend the sort of specific budget lens of Medicaid and say, how do you pull in the housing resources? How do you pull in the other types of interventions for children, trauma services that we know can obviate use of very costly state services like correctional services in people's adult lifespan?
I agree with a lot of what Kate said, and I'll go back to something that Aviva said as well, that you have to look at the revenue side as well. And one thing we have seen, and many other people have commented on this, is that revenue growth trends have been particularly slow coming out of this recession versus prior recession. So decisions states make there and how the economy responds are going to be important as well to seeing, well, what is that envelope you have to deal with rising costs, not just in healthcare. And healthcare is a very significant piece. I mean, you look at the numbers, you cannot deny that healthcare will be a driver and has been for state budgets and will continue to be, and also for the federal government. But cost growth has slowed, particularly on the Medicaid side. Whether that continues when you hit another downturn and what happens, we'll have to see it at that point, whether these cost control efforts really are sustainable through that. But you also have to think about the revenue profile and what are the things states can do to manage that as well.
Hi, it's Tim Coffin with Breckenridge, and I just wanted to respond. Louise, you mentioned, our creditors paying attention to this, and I would say yes, very much so. And I would actually take it a step further. Our firm, sorry, this comes across as a bit of a plug, but we actually pipe a lot of data in from the Robert Wood Johnson Foundation for county health rankings, trying to look at how well communities and service providers are actually able to keep their communities healthy, and we look at that as a long-term credit perspective.
Joe Fleming with the Pew Charitable Trust. My question is mainly for Kate. I have a question. Since the recession, have the forecasting for the demand for services changed, and have your strategies changed at all? Whether in either the number of scenarios that you run or the time frame in which you run your scenarios?
That's a great question. We had obviously an enormous uptick at the early phase of the ACA, surpassing what we had imagined would be the case based on our forecast. Aviva talked about early expansion states. We were one of those states, so we saw activity in advance of 2012, but we in other states did not get that right. The demand exceeded what we had anticipated. As far as now, we have seen some stabilization, but we are acutely aware of what Aviva talked about, and then we know the cycles of Medicaid participation are very much related to economic downturn. So if we face another cycle of that type, we have to build in elasticity of the program. And frankly, I think what we've said this morning is that the federal resources for the program are essential for that, and then the latitude of the expansion group, which has enabled us to serve the very people who are most vulnerable, who would not have other meaningful options for coverage, can't afford the exchange policies, and would really wash up on the shores of our emergency rooms as they did historically.
I think we have room for one more question up here. You have a question before? Yeah.
Hi, my name is Chantal Lafontaine from Indiana University. I just had a question about how do you anticipate population changes? Certain states are known for having being a snowbird state or having a lot of seniors retire there. Other states have increasing K-12 enrollment stats, and those create different kinds of healthcare challenges.
So how do we evaluate those differently?
Yes, how do you anticipate that?
Yeah, I think that's going to be an important question for us to think more about is how do the different demographic profiles of states affect things like Medicaid trends? We've certainly always looked at economic trends and population trends and thought about sort of fundamental effects on revenue growth prospects, for example. Laura was talking about our criteria earlier. But I think one thing we can do more of now is think about some of the other factors and how they may play into things like expenditure growth expectations. And Medicaid is certainly one of those areas. Also relates to things like pensions, too.
I agree with all of that, but I think those are also good examples of things that are quite hard to forecast, particularly over long periods of time, which is one of the advantages of a system that adjusts more automatically and is a contract between the federal government and states versus any approach that locks in funding over time.
All right, well, unfortunately, we have time for no more questions. Please join me in thanking our panelists.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.